Hello everyone. Today we will discuss about urine examination. So the examination will be discussed in the following headings: the specimen collection, the gross, microscopic and chemical examination. Going to the specimen collection. Now the types of specimen used are: first is the random urine specimen. This is most commonly used because it can be obtained during any time. And second is first morning specimen. This is the most concentrated form of the urine and is used for biochemical analysis and for examination of casts and crystals present in the urine. Then is the 24-hour specimen. Now this is the form of timed specimen. To collect this, we have to start at 8 a.m. and we have to discard that first specimen, and then the subsequent samples are collected till the next day 8 a.m. The last sample collected at 8 a.m. is kept, whereas the previous day 8 a.m. sample was discarded. Now this specimen is used for quantitative estimation of the proteins, for estimation of VMA and metanephrines in the case of pheochromocytoma, and for detection of microalbuminuria to assess the renal damage, early stages of renal damage. Now the types of collection: they can be clean catch, midstream sample. In this, the external genitalia must be cleansed by the patient and the small amount of urine is discarded prior to collection of the specimen so that external urethral infection cannot play a role. Then it can be obtained by catheter, and other is suprapubic aspiration, in which the needle is inserted above the pubic bone, and it has specific indications for it. These are urinary retention, urine culture in neonates, chronic infection of the urethra, urethral stricture, and urethral trauma. In these cases, suprapubic aspiration can be done. Now other is the preservation. Ideally the urine should be examined within 2 hours, but if it is not examined, it should be refrigerated. It can be the toluene, formalin or thymol can be added to preserve the urine. Now going to the physical examination or the gross examination of the urine. Firstly, discussing the urine volume. Now, the urine volume normally ranges between 600 ml to 2000 milliliter per 24 hours, and the night urine should not be more than 400 ml. Now, what is polyuria? Polyuria is more production of urine more than 2000 to 2500 ml per 24 hours. Now, the causes for this can be: first is the physiological states like excessive water intake or due to side effects of some drugs like thiazides, or alcohol or caffeine intake. Now pathological states, they can be like diabetes insipidus in chronic renal failure, later stages of chronic renal failure, and osmotic diuresis, which is seen in diabetes mellitus. Now what is oliguria? Oliguria is excretion of less than 300 ml of urine per 24 hours, and it is seen in acute renal failure or chronic progressive renal disease. Anuria is less than 50 ml per 24 hours, and it is seen in later stages of acute renal failure. Now going to the appearance of urine. Normally the urine is pale yellow in color, and if the urine is diluted, it can be colorless. The urine can be cloudy. Now cloudy urine can be seen due to many reasons. The cloudy urine can be due to phosphates, can be due to urates, can be due to WBCs, can be due to bacteria, yeast or sperms. Now this cloudiness due to phosphates goes on if we treat the urine with dilute acetic acid, and the cloudiness due to urates go if we treat the urine with high temperature. Now the urine can be yellow-green in color, or a yellowish foam can be seen. It is due to bilirubin in jaundice patients. It can be red due to hemoglobin, blood, RBC and myoglobin. It's brown-black in alkaptonuria and can be bluish-green in pseudomonas infection. It can be milky due to pyuria, heavy amount of pyuria, lipiduria or chyluria in cases of filariasis. It's due to intake of rifampicin, a side effect of bright red-orange urine can be seen. Now going to the odor of the urine. Normally urine has a faint aromatic odor, but it can be foul or offensive in cases of any infection if the specimen is kept for a long time. It can be sweet due to presence of glucose. It can be fruity due to ketones, and it is a specific odor in case of phenylketonuria, that is mousy odor. Now, going to the specific gravity. Now, specific gravity, what is it? It is the ratio of weight of 1 ml volume of the urine to the weight of 1 ml of the distilled water. Okay, and what does it shows? It shows the presence of solutes in the urine, how much concentrated or how much diluted the urine is. Normally the specific gravity ranges between 1.003 to 1.030. Now, the variations in the specific gravity can be seen. If the specific gravity is less than 1.007, it is known as hyposthenuria, and it is seen when the water concentration increases in the urine and the solute concentration falls down, like in diabetes insipidus, can be seen after infections like pyelonephritis, or in some case of glomerulonephritis. It can also be seen in other conditions. Now, high specific gravity can be seen during dehydration, in which the water in the urine decreases, where the solute concentration increases. It can be seen in hepatitis, hepatic disease, in congestive heart failure. Now, if we discuss about diabetes mellitus, what happens in it is there is presence of glucose and water both in the urine. There is polyuria, but there is presence of glucose also. So if the glucose concentration in the urine increases, so the patient can show high specific gravity. If the glucose increases, then there will be high specific gravity. Okay, and if the water concentration increases, the patient can show almost normal specific gravity. There are less chances of specific gravity being less in these cases. So diabetes mellitus, in spite of showing polyuria, can have high specific gravity. Now, going to a term known as fixed specific gravity, which is known as isothenuria, in which the specific gravity doesn't vary between different specimens. It is almost fixed. This is a value 1.010. It is fixed at this value, and it is seen as in the chronic renal failure cases, because the kidneys, don't have the capacity to concentrate or dilute the urine, so the urine is always passed as a specific gravity of 1.010. Now, going to the methods of measuring the specific gravity. They can be by refractometer, by reagent strip method, by urinometer, or by falling drop method. The most commonly used is the reagent strip or the urinometer. This is the urinometer we can see in this picture. This is urinometer. It is a hydrometer used to measure the specific gravity. Now, the urinometer, it is calibrated by the temperature. So, if the temperature is varied, the correction factor of 0.001 is added for if the temperature is above, or it is subtracted if the temperature is below the at which the urinometer is calibrated. And it is correction factor is also needed for the proteins and the glucose present in the urine. Okay. Now, going to the pH. What is the pH? Normally it ranges from 4.6 to 8, and it can be measured by strip method, by pH electrode method, by titration method. And the pH should be always examined on the fresh specimen, because it turns alkaline on standing. Urine always turns alkaline on standing. So the pH can also be varied. This is the pH which is shown on the reagent strip method. The strip is coated with methyl red and bromothymol blue, and the H ions, the protons, react accordingly with both of them. So the acidic urine can be seen if the diet is rich in meat protein, acidosis, or UTI by E. coli. And alkaline urine can be seen if UTI is with the urea splitting organism like Proteus, or salicylate intoxication. This was about the acidic and alkaline urine. Okay, this was all about the a gross examination and the specimen collection. I will discuss the microscopy and the biochemical examination in the next video. Do like, share and subscribe. Thanks for watching this video.